Hello, everyone. My name is Gabriel Altit. I'm a neonatologist at the Montreal Children's Hospital, and today I'll be presenting on pulmonary hypertension BPD and my pragmatic approach to these patients. And this will be done in the context of the annual International Annual Conference at the James Cook University Hospital, and I would like to really thank the organizing committee for thinking of me for presenting on this topic. So these are my disclosures. I do want to mention that Mallinckrodt supported the NeoCardio Lab platform through an unrestricted education grant. I'm providing here the QR code that will bring you to the content that I will present at this conference. And for this specific presentation, my objectives and my hopes is that the participants will be able at the end of this session to outline some of the pathophysiology of PH, outline a strategy for screening driven by neonatology and cardiology collaborations, and discuss management strategies in these patients. So I'll start with the patient story. This is actually a patient partner of mine, and it finishes in a beautiful story. So I always like to share it. The story of Nasima, who was born at 24 weeks and had some degree of BPD at 36 weeks. So was on actual CPAP at 5 with minimal oxygen needs, and got a targeted neonatal echo as part of a screening program in our NICU, and was found to have some degree of mild pH with a charge of around 40 to 45 millimeters of mercury. And so was actually discharged in room air and fully fed, and was sent for cardiology follow-up at the outpatient setting. And so came back and was found at 9 months corrected age to have these echo findings of severe RV dilatation, bowing interventricular septing, outlining suprasystemic RV pressures, a struggling strained right ventricle with an underfilled left ventricle that is being pancaked by the RV, and suprasystemic RV pressure as suspected on this echo. And so the patient was admitted to the pediatric intensive care unit and went for the cath lab for confirmatory study, and was actually quite unstable during this evaluation, and was found to have indeed suprasystemic pulmonary vascular resistances with positive vasoreactivity testing. He was intubated, required cardiac support, and eventually was discharged weeks after that, still in room air because of normal oxygenation testings and oximetry testings, and was on tritherapy for his pulmonary hypertension, and had actually positive echo response. And so we'll see later a bit more of the story of Massimo. But I think this outlines for me that babies we care for in NICU are quite at risk from their lung disease. And I thought it would be important to first start with a common definition of what is pulmonary hypertension. And so as it says, hyperintention means high blood pressure, and pulmonary means that the high blood pressure is within the pulmonary vasculature, or at least the pulmonary artery. And so really the same way that systemic hypertension is a symptom of a condition, whether it is renal, whether it is iatrogenic from drug exposure like steroids, whether it is secondary to renal vascular disorder, you have similar processes that can cause an increase or an abnormally high blood pressure in the pulmonary artery. So typically what we see in the NICU are situations secondary to high pulmonary vascular resistances, but there could be conditions like situations with a hypoplastic pulmonary vasculature. So there's less capacitance in order to fit the entire cardiac output. So the pressure will rise. There are certain syndromes that are associated with high pulmonary vascular resistances. There's also a situation where pressure are being transmitted into the pulmonary vascular compartment, such as in situations with a left to right shunt at the pulmonary arterial level, like a PDA, truncus arteriosus, and AP window. There could be a pulmonary venous congestion, which will lead to what we call post-capillary phenotype, and eventually will rise PA pressure. We see that with pulmonary vein disease, mitral valve disease, or left ventricular disease. We have situation where you have PA obstruction, like in the context of pulmonary embolus. And then there's situations that are multifactorial, with, for example, bronchopulmonary dysplasia, congenital diaphragmatic hernia, that may have components of both arterial and venous conditions. And really the end result of having high PA pressure is the concern that eventually you get end organ damage, so RV failure, and eventually a drop in the preload of the left ventricle, and that can lead to cardiac arrest, especially if you're not able to maintain output, such as if you don't have, for example, shunts to pop off the RV or the LV and provide systemic output. And so in these particular situations, you always need to kind of decipher what's the cause of the high RV pressure and high PA pressure in order to tailor the therapy. So we know that our babies in the postnatal context and even in the preterm postnatal context will have a drop in pulmonary vascular resistances and a rise in systemic vascular resistances. And this will translate into progressive drop in the PA pressure and progressive increase in the systemic pressures as the resistance are falling and the flow are stabilizing. This will reflect in a drop in PA pressure and this increase in blood pressure in the systemic compartment. And so when we look at definitions of what are the cutoffs that we use to say, well, this is an abnormally high blood pressure, of course, in the first few days, first few weeks of life, there's still this transition ongoing. But we do have some consensus based, at least from pediatric and adult studies, that are demonstrating that if you have a mean pulmonary arterial pressure of 20 and more millimeters of mercury, there's a higher risk of requiring pulmonary transplant or having eventual mortality. And so these are the cutoffs that are used in the cath lab in patients that are more than 3 months old and are assumed to have undergone this transition. And so before this transition, of course, you should not have suprasystemic PA pressures or pulmonary vascular resistances. But when we look at our preterm infants, when they reach near term, they often have done already this transition and it's been already 3 months that they've been in the NICU. And so although we don't really know, the true number that puts them at risk of mortality, we do use some of these standards to actually create a red flag of who are these patients at higher risk of having eventually RV remodeling. So we use a mean pulmonary arterial pressure 20 or more. And obviously getting a mean pulmonary arterial pressure by echo is very challenging. And what we can get by echo is often what we call a systolic pulmonary arterial pressure, which is the peak pressure in the RV. That is usually the same as the systolic or peak pressure in the pulmonary artery. And so we often use the cutoff of around 40 millimeters of mercury to reflect a higher pulmonary arterial pressure. But we know the mean is the area under the curve and can be influenced also by the diastolic pressure. So you have to keep that into consideration. And so usually if, you would do a cath lab analysis in a patient that does not have high PVR or doesn't have pulmonary hypertension for various etiology, and normal PA pressures are usually around 15.5. So having above 40 of systolic pulmonary arterial pressure is usually translating into higher mean PA pressure. And of course, an acute change is much more or much less tolerated from the RV standpoint than a chronic change, which leads to chronic RV remodeling. But these are the typical metrics that we use by cath or echo to classify this patient as some degree of pulmonary hypertension. And so when you look at pulmonary hypertension, I told you there's many etiology. When we're looking at the precapillary compartment or the arterial compartment, it's often due to situations like hypoxia, high CO2, vascular changes, high pulmonary vascular resistances like PPHN, for example, or acute pH. Sometimes sepsis or infection can cause this, or high altitude. Or you can have a situation of not reactive but fixed PVR, such as in pulmonary hypoplasia or vascular obliterations that can happen in certain patients. And obviously, in BPD, you may have a component of this reactive or even fixed PVR, but it's often a multifactorial disease that we see in BPD. The other thing is the post-capillary venous hypertension, which are patients that will have an increase in their PA pressure, but that's often secondary to a blockage somewhere along the path of the venous drainage. And so that's just an example of a patient with some degree of pulmonary vein stenosis that can kind of back up pressure. And so these patients will typically have lower PVR, but still a very high mean pulmonary arterial pressure. And that's due to either a pulmonary wedge pressure that is high or an LV and diastolic pressure that's high if it's an LV disease. So you may wonder, why are preterm infants with BPD at higher risk of developing this kind of increased PA pressure? Well, if you look at some of the classification of pulmonary hypertension in pediatrics, BPD is its own category because of all the different pathophysiological mechanisms. We know that our babies are born with very immature lungs. They're exposed to various injuries such as oxygen, valvulotrauma, and ventilation. They have abnormal repair and fibrotic mechanisms, and they're often in some degree of inflammatory storm, either from a prenatal or postnatal context. They can have disturbed postnatal growth, and that includes the lungs and its vasculature. They're sometimes exposed to steroids, which can also remodel vascular stiffness. And then some of them have just this genetic predisposition or fetal environment that is unfavorable, such as in situation with preeclampsia and growth restriction or even choreo. And so these babies do have some degree of lung disease, but they can also develop vascular injury. They can have abnormal vascular pruning, remodeling, and vascularization. They end up with VQ mismatch, sometimes aspiration and airway disease with CO2 retention. And so we know that a certain portion of these patients may have both increased PVR, decreased vascular territory, and abnormal venous drainage. But the good news is that they're very resilient, and as these patients get better from a lung perspective, typically their vessels get better. But what's complicated along the way is that these lungs are not homogeneously affected. They do have kind of like different patterns across the different areas and territories in the 3D architecture of the lungs. And so, it's very simplistic to think that it's just affecting arteries, but really this disease affects the veins, the left ventricle, the right ventricle, even the flow sometimes, if there's residual shunt that may impact also how these vessels are reacting. We know some babies also have a component of large airway disease and parenchymal disease, and all of these are kind of interacting together, which makes this particular condition quite interesting to study. But what we know is once these patients developed pulmonary hypertension, it puts them at higher risk of mortality in the long run, probably because it reflects the degree of the disease in their lungs, but also because they eventually get RV failure or PH crisis. And so risk factors are typically those of the extreme gestational age at birth, if they had some degree of hypoplasia of the lungs, they were exposed to a lot of inflammation and the severity of lung disease. And of course, IUGR patients have been reported as more at risk. So we spoke of the complexity. These patients have airway disease, ventilation perfusion mismatch. They have decreased surface area in arterious and venous disease. So it's not just about pulmonary vasodilation. It's thinking that there may be kind of all of these different pockets of the lungs that may be affected differently. And so we have to take this into consideration when we have the pragmatic approach to management. So one of the things, and that's maybe my bias, I do think that it's important to understand, cardiac performance in the context of BPD PH, because we know that this is one of the determinants of adverse outcomes, and that's really the end organ damage that we're trying to prevent. We know from one of the studies we've done on one population with pulmonary hypertension that actually RV function at the diagnosis of PH of these patients, which was close to term corrected age, was driven in terms of prognosis by the RV function at the time of the diagnosis. And so those patients with more severe PH severity and RV dysfunction were the one who eventually had more risk of mortality down the line. So there has been guidelines both at the American Thoracic Society and Heart Association level, as well as from the TPHnet. And I know their European pulmonary hypertension guidelines also recommend similar frameworks, which is basically to screen for pulmonary hypertension in babies with established BPD. And we'll talk about the algorithm that we locally implemented in our unit. And you can see that the PPHnet actually classifies the severity based mostly on the reflection of the end organ damage, which is RV function. So if you have normal RV function versus severe RV dysfunction, you change category and you're much more at risk, which eventually will drive the degree of support that we need to give to these patients. We did look, since we started screening in our own population, and we felt that a screening era would probably have much more patients with more subtle conditions and subtle disease, and so would probably kind of drop our signal. But we still found that a third of our patients had some signs of pulmonary hypertension on their echo, although only 8% or 6 patients had some mortality post-diagnosis. So that's lower than the previous cohorts. That's probably because we're including milder patients because it's a screening era. But I think it's also part of the fact that we've been better at recognizing that these patients are high risk, supporting them, training the families, and actually intervening at appropriate times to prevent, these catastrophic arrival into the emergency room with like dead RVs that require urgent ECMO, which is not something we see as much, at least in our institution anymore. But what we found is that despite even being in a screening era, the patient who had PH under screening echo had already signs of RV and LV functional alteration. So clearly there is a signal, whether it is inherent to the heart or inherent to the interaction between the lungs and the heart, that there's already at this age some effects on both ventricles. What about the long run? What about the long term of these patients? Why are we trying to, beside mortality, is there something else to try to prevent in some of these patients by better understanding them and potentially even intervening? Well, we know that life is a continuum, and as we go along the pathways of life, we are exposed to stressors and risk factors and potential insults to the cardiovascular system. And as these trainees are graduating from our NICUs, they are at risk of further insults like tobacco, hypoxia, infection, toxins that may further impact both their pulmonary vasculature, systemic vasculature, and heart. This is Piscine Canabrash. We did a study where we followed a cohort of patients in the outpatient setting and looked at them at 4 months. And what we found is that actually in tiniest babies, there was still quite a significant portion of patients that met our criteria for pulmonary hypertension. And these patients had actually lower RV function at 4 months. So I think for us, it made us reflect on how it is important to not lose these patients, to follow up, to better understand them and see who are the ones that we could potentially have prevention strategies and even interventional strategies, depending on where the science is bringing us. Why do I think that is important is that, in adults now, it is recognized, and that's one of the cohort studies that we've done in adults born preterm. And we're not talking about, very, very immature patients. We're talking about 23-year-old patients that were less than 30 weeks when they were born and compared to term counterparts. And we found that these patients had lower RV function, systolic, and that was more even pronounced if they had some history of BPD. And so clearly there's a signal there that these patients eventually in the long term may have impact of their prematurity and their lung disease. The group in Paragoth actually brought back preterm infants that were born at an average of 28 weeks and did cath on these patients. And at least half of that cohort, which is tiny numbers, but half of this group of asymptomatic adults were already meeting clinical criteria for pulmonary hypertension compared to the term newborns that were now adults. So none of them actually met pulmonary hypertension criteria. So it just raises awareness that there might be something in the continuum from the NICU to eventually adulthood where we should, as a community, intervene in these patients or at least follow to better understand them. From the UK, actually, Adam Lewandowski is Canadian, but he worked and is currently at Oxford and did MRI on these patients and found that there's definitely some RV conformational changes in the long run. What about the left ventricle in these patients? Well, it would be very foolish to think that the LV is preserved and the RV is the one being affected. I think we know nowadays that they have systemic vascular issues in these patients. And I think we know that these patients are at risk of L disease as well, on top of the risk of right ventricular disease. Why? Because they are potentially affected by coronary steal, left ventricular inflammation, postnatal growth issues of the left ventricle and the systemic vasculature. And they may have issues with their systemic vasculature, either by remodeling of the systemic vasculature through exposure of different drugs like steroids, which can also affect remodeling of the left ventricle and the right ventricle. But, adverse systemic vascular resistance profile in the long run from the fact they were exposed to NSAIDs or to kidney injury or kidney immaturity, which can eventually impact the LV, as well as some of these IUGR patients that may have a predisposition to have systemic hypertension and renal disease and high SVR. So we looked back at our preterm population. We looked at the echoes they got at 36 weeks. We also found that there was a gradient in how the LV grew in these patients. And so we even did looking at a ratio to the body mass index, body surface area. And we found that these patients born at the extreme of gestational age, really already at 36 to 40 weeks, had some clear differences in their LV capacitance. And so that made us wonder, well, how much of this LV is actually also impacted by the BPD, by the inflammatory storm, and how in the long run this can translate into potentially more heart failure or poor reserve. Silviano Gara, who's from Italy, actually looked at a prospective cohort that we scanned at 36 weeks using 3D echo. These were babies are born around 26 weeks, with 48% having some degree of BPD. And, we have a low rate of severe BPD in these patients, but, these patients are affected on their own by prematurity. She used 3D algorithm to reconstruct the LV, and she also found in this cohort this gradient, both by gestational age at birth of the LV size, but also by sex. So there may be a sex difference also that affects the cardiovascular system from very early on, whether it is protective or not. That's to be defined in the future years. Adam Lewandowski actually clearly shown by MRI that these babies born preterm have impacts of the left ventricle, and we know from Swedish cohorts that they're a bit more at risk of early heart failure. We actually looked at our happy cohort of adult born preterm, and we found that these patients had reduced stroke volume and reduced signs of LV systolic and diastolic function by PDIs. So there might be something in the continuum between the NICU and adulthood where we need to intervene or actually get more data on these patients. So I've put here a QR code about our approach to screening and management. And this has been a multidisciplinary team that's been developing these practices. This is the algorithm that actually we designed at the scale of the province of Quebec with our Quebec TNECO collaborative. And so we'll go through the actual algorithm together. The screening that we decided upon at a provincial level is to screen babies less than 30 weeks if they're still requiring oxygen or respiratory support. And we do consider a strain if the baby was born growth restricted as one of the sole risk factors. And so we typically will do the echo at 36 weeks unless there are additional risk factors like being born at 22 to 24 weeks or being still on invasive respiratory support or deemed symptomatic at 32 weeks. We would consider an earlier echo. And at this point on the echo, if pH is confirmed, we would then classify the pH. So in terms of our timeline, I think I've outlined these criteria already. Symptomatic would be unexplained worsening of respiratory status, lack of expected improvement, or symptoms of right-sided congestive heart failure. The criteria we use for suspicion of pulmonary hypertension are either if we get a pulmonary insufficiency jet, which informs us on diastolic pressures because the pulmonary valve is closed in diastole. So we can get a Doppler through this, and if the mean pulmonary arterial pressure or the diastolic pulmonary arterial pressure is above 20, we start being concerned for a sign of pulmonary hypertension. But truly, the most amount of echoes, what we would get would be a TR jet above 35, assuming a right atrial pressure of 5, which would translate into a systolic pulmonary arterial pressure of 40 or more. A restrictive PDA VSD velocity gradient in relationship to the systolic blood pressure at the time of echo, if there's a right to left post-tricuspid shunt, or otherwise, if there's none of these metrics, if there's flattening of the interventricular septum at the end of systole. But obviously, this is related to what's happening on the systemic compartment. So if you have systemic hypertension, you may have a very nice round LV and what we call a very normal eccentricity index. So you have to be aware of these caveats. So again, what we are getting from the echo is typically a systolic metric. So here it's an example of TR jet, of bidirectional PDA, or of a bowing septum during systole. So all of these needs to be put into consideration of what's happening in the systemic compartment relative to the PA compartment when you're looking at the PDA or the relation of the movement of the septal curve in systole. And then you can get a pulmonary insufficiency jet to inform you if you have gradients that are above 20. That would be also raising the red flag. So again, increasing afterload will change the relationship between the RV and the LV. Typically, your RV will become, with time, more hypertrophied, more dilated, and the septum will start bowing into the LV cavity and eventually pancake the LV as the RV becomes suprasystemic. I've put here some of the metrics we use for pulmonary hypertension severity. So no pH and some of these echometrics I just mentioned. And so if we do classify the patient as a pulmonary hypertension, that's where we start aiming typically saturation above 92% or above 95%, depending on the severity. We aim for a pH around 730 and a PCO2 below 60. And sometimes we even consider increasing the PEEP in some of these patients if there's work of breathing or de-recruitment on X-ray. And then we classify based on mild, moderate, or severe. So I put here criteria by echo that are based from the PPH net for either RV dysfunction or RV dilatation and severe dysfunction, as well as clinical signs of severity of RV dysfunction. So if you have hepatomegaly, hypotension, growth failure, and hypoxia secondary to right to left shunting at the level of the atrium, then obviously it's more concerning for kind of a severe condition. And if you, of course, are in a suprasystemic range, you would be considered to have severe pulmonary hypertension. So this is more for your reference, and these are actual quantifiable measurements that you can use to classify your population at the time of 36-week screen. So this example of a mild pH, the RV is crescentic, is without hypertrophy, no dilatation. There's good RV function and size, but on a TRJet, we get values that are within an abnormal range or an increased range. These patients would be considered mild pH. This is a patient with moderate pH. You get some degree of septal flattening during systole. Your RVRA is isosystemic or is near 2/3 systemic, but not quite yet. And you have a bit of an RV dilatation. In these patients, we always get a crowd view. We always get pulmonary venous Dopplers because there can be a component of what we call acquired pulmonary vein stenosis, although this tend to typically occur much later in life, like 3 to 4 months of corrected age. But it's something we try to get at every echo and make sure you get a triphasic low velocity profile for each of these veins. And then you have the severe profile where you get significant RV dilatation related to the LV. You have pancaking of your septum. The RV is struggling. Its function is relatively poor. And you'll have suprasystemic or iso to suprasystemic range of PA pressures. Finally, we do see some patients at 36 weeks that have large post-tricuspid shunts, like a PDA or a big VSD. And in these contexts, it's a bit more difficult to understand what's happening downstream. Why? Because two chambers that are connected, by definition, will equalize pressure. And so these patients, a lot of the increased PA pressure is not necessarily because there's high PVR, but really because there's just this transmission of systemic pressure to the pulmonary compartment. So in this patient, you have like a strict left to right shunt, relatively low velocity, and you have increased RV pressure that are probably from this transmission of pressure, but it's hard to tell what's happening downstream in these PVR until this shunt is closed or actually assessed in the cath lab. Some of these patients we actually just observe, and eventually as the PDA close, we reassess by echo and decide if there is indeed underlying a component of high PVR. And finally, the last phenotype that I mentioned, which is outlined here, is babies with high pulmonary venous velocities because of constriction. Echo can detect most babies with pulmonary vein stenosis, but not all babies, especially if there's no flow, then you wouldn't see it by echo if it's completely atretic. And typically you lose this physicity of flow. And because of that, you have patients with high post-capillary pressures and that translates into a high pulmonary arterial pressure. And sadly, these patients often have heterogeneous lung disease, and they may also have a component of high PVR in some parts of their lungs. So in our condition, what we do is that our first screen is done at 36 weeks for most of our population, and we repeat it at 40 weeks if the baby is still on oxygen and rest support. If not screened at 36, but there's a new onset of oxygen rest support, then we decide to screen most of these patients, but that has been very rare. We had to do that. It's mostly for patients transferred after 36 weeks that we would do that. And the typical frequency that we follow, if there's mild pH, we'll typically just follow 1 month later, and that could be as an outpatient. If the moderate pH, we typically follow 2 weeks later. That also could be as an outpatient, but we usually like to stabilize their condition before we transfer them out or we discharge them. And if it's a severe pH, we actually follow much more regularly and really depend on the condition. And we do have a multidisciplinary team where we assess these patients as a group with respiratory medicine, cardiology, and sometimes even more experts like ENT and other people. Many of these patients are actually followed in our BPD clinic with respiratory medicine, neonatal follow-up, OT nutrition, and cardiology, and they do get like a lot of parental teaching and support. So between January 1st and December 31st, 2024, we applied at our center this algorithm on 87 patients that were less than 30 weeks, out of which 42 were on oxygen support at 36 weeks, so a bit less than half, a bit less than half. And so on these patients, 7 had signs of pH, but none were severe, 2 with still signs of pH at 40 weeks. And interestingly, we had 22 patients on oxygen respiratory support at 40 weeks, and some of them actually developed signs of pH then later in their course, with 3 normal screen that were normal at 36 weeks and actually had confirmatory pH then, so we're followed in the outpatient setting conventionally. And so you can see that it's variable. Some years we'll have some babies with severe pH, some years we'll have not. Some years we'll have 1 or 2 babies with pulmonary vein stenosis, and then 5 years goes by and we have none. Actually, we rarely see pulmonary vein stenosis in our population. So the management, obviously BPD prevention is key. Usually if there's no lung disease, there's no pH. It's not always true, but the majority of patients who have pristine lungs will not have pulmonary vascular disease. And, the pulmonary vasodilators are typically not the initial focus, actually. You really want to treat the lungs. You want to treat the baby. You want to make sure these lungs are going to recover and grow with no further injury to their pulmonary vasculature and create new pruning in a context where there's no consistent vasoconstriction and muscularization, as well as appropriate growth without injuries from things like CO2 retention or aspiration or reflux. So these are typically the approaches that we have. I've put the recommendations from the PPHNet attached to this presentation. So what we do locally is we typically aim saturation 92% and above, more than 95% of the time. And so sometimes we do oximetries in these patients, and we do provide supplemental oxygen, which is also a pulmonary vasodilator, but mostly to avoid vasculature vasospasm. We also would involve our ENT specialists to do airway evaluation. And we assess if there's signs of aspiration or significant reflux that puts these patients at risk of pneumonia or vascular injury. And if present, we optimize nutrition. So often these patients would be seen by our occupational therapists. And if there are concerns, we would do video fluoroscopies or swallowing studies in these patients. Although the evidence is weak in our babies with moderate or severe pH, we'll often consider initiation of low-dose hydrosparo, and typically we do a 2-week period in these patients, and then we'll stop it and repeat our echo in these patients. And the thought is that there might be some degree of LV diastolic dysfunction and fluid retention in some of these patients. But this is very weak data and there's no randomized controlled trial, but I'm very transparent. This is kind of the tendency of our practice. And there is some observational data showing that these diuretic therapies, specifically for the babies with chronic pH, I'm not talking babies with BPD, may improve the dynamic of the right heart and the pulmonary pressures. And that comes a lot from the literature from the pulmonary hypertension trials and studies that were done in the pediatric and adult range, where we try to unload also the RV with some of the degree of induced diuresis. But there might be different mechanism that supports the use of these agents. What we do locally is really a 2-week period and then stop it and then reassess to avoid having these patients on just like chronic diuretic therapy, which also comes with risks, side effects. We involve a lot of our parents. We explain how to recognize pulmonary hypertension crisis. We give them some training around CPR if there's concern at home. And then it's obviously vaccinations for everyone, infection prevention, because that's when these patients actually decompensates, is when they have stressors. So for example, they'll will avoid elective surgeries for no reasons, or if they need a surgery for circumcision or even for hernia repair, we're always considerate about that. And we make sure that they're seen by cardiac anesthesia if they do need to go for a procedure. There are sometimes other investigations for moderate or severe pH or unusual pH. We would, of course, for all of these patients, at least get a TSH, ECG, NT-proBNP, and oximetry to make sure they don't have silent hypoxic events. They'll often be seen by ENT, OT, and make sure they don't aspirate. Sometimes, or rarely actually, we'll ask genetics if we see that they have a course that is odd in terms of behavior or response to treatment, or worsening despite our interventions. And then sometimes we will involve MRI CT for pulmonary veins if we're uncertain, especially in the long run. And some of our patients will go to the cath lab, but then again, that's also something quite rare. The reason we would go for the cath lab is if we're concerned about pulmonary vein stenosis, if we think there's a shunt contribution of flow, like a large ASD, VSD, or PDA, that we would need to outline and potentially test accrued. If there's worsening or not improving despite this ongoing management, if ever at any point they were in a suprasystemic pH range by echo, we would want, once they're rescued with therapy, to go and assess this pulmonary vasculature. And if there's obviously concern for post-capillary conditions or left-sided conditions like flash pulmonary edema, LV hypertrophy, and concern for high and diastolic pressures in the left ventricle. In pH crisis, of course, that's where we would use aggressive pulmonary vasodilators and cardiac support. These are the recommendation by the PPHNet is to use INO in these patients who have VQ mismatch and acute RV decompensation with high lactate and really decompensating clinically. And to use pulmonary vasodilators on a chronic would really be kind of your last steps in some of these patients with pulmonary hypertension. And if we would go and for the need of a pulmonary vasodilator in a chronic phase, mostly for patients with RV remodeling, RV dysfunction, RV hypertrophy, we would consider sildenafil as a first line. And in some of our patients, we may not even go to the cath lab if they don't have severe symptoms enough to require cath lab. But I can tell you this is extremely rare. We start sildenafil even in our cohort because typically they will get better even with these first two steps I've outlined. So we have 1 or 2 patients per year, maybe, that would need sildenafil. And actually, it's been a few years we haven't started any patients in our unit sildenafil. It's usually for those with more significant pH, more than 2/3 systemic, and those with signs of RV dysfunction or RV remodeling, like hypertrophy and dilatation. You have to be aware that this is a drug that's been untested for this condition and can increase VQ mismatch. So these patients may vasodilate in areas that are non-ventilated and eventually get more of this hypoxic blood coming back to the left atrium and become more blue because of this. So that's why we're always careful in BPD to start this medication, and it may worsen reflux. And so, some centers would use bosentan as their first line. That's not our practice, but it's been the practice at other centers, especially in the US. And before adding any other agent in these patients, like prostacyclin or bosentan, we would consider a cath lab. We would do acute prostacyclin therapy if they're really having these massive dilated dead RVs or extremely severe pH crisis to stabilize them. And sometimes we would even use one that has a very short half-life, like epoprostenol, just so that we can titrate in the cath lab. But these patients would require something like treprostinil to go home because it's a much longer half-life and can be given subcutaneously. But it comes with a huge burden to give these medication. ERA, you have to be aware that they can have liver side effects. So that's also something we are careful about in these patients. I've put here the different pathways that are targeted by some of these drugs, none of which, except maybe inhaled nitric oxide, has been studied in the context of newborns via RCTs. And really, none of them have been studied for BPD with pulmonary hypertension. So I want you to be aware of that. Some of these patients, if they are in acute pH crisis, may need milrinone, but that also comes with caveat, and we'll discuss the milrinone in the cardiovascular therapy session. So what about Massimo? He's now off all medication. He has a normal follow-up at 3 years, and I want to really thank the family to share their story and to be such advocate and being part of patient partner in my own journey as a researcher. They've come to conferences with me, and they've shared how amazing their Massimo is growing into this incredible individual. So a success story. So I hope I can convince you that extreme premature babies, especially with lung disease, are at risk of pulmonary hypertension, and that screening is advocated around 36 weeks in some of these patients. This can be done in conjunction by TN echo or cardiology, depending on your system and teams. There are multiple etiologies unique to BPD, and that will affect how you manage these patients, but it is something that seems to be a lifelong condition. So although I don't want to create a panic, I want to make sure that people are aware and should be proud of their prematurity. And so they should know that when they see the pediatrician, family doctor, and adult doctor, that they should mention that they were born preterm, and that could be part of an extra added risk factor for their long-term cardiovascular care. If you scan this QR code, you'll get a lot of resources on how to recognize some of these phenotypes of pulmonary hypertension and management. And I want to thank you for your time and attention.